you just while you're talking, I'll just cover lawyer's triangle till you get yourself sorted out, David. So just for the guys in the room, I refer to lawyer's triangle, which we refer to. This is the appendiceal or schematic of the appendiceal orifice, triradiate fold, and you've got the ileocecal valve here. And if you draw a triangle between the appendix orifice and the ileocecal valve, the area in between is lawyer's triangle. The reason I've called it lawyer's triangle is, one, it's triangular, and secondly, it's usually underwater. And if you're going to get sued for missing something, it's very likely it's going to be in here, hence the name.
So we're just getting to the lesion. And maybe Zander, if you haven't already, can we talk a little bit about this patient and what we have here?
This patient had a colonoscopy in the middle of March in another center, and he had 3 polyps detected, one on the ileocecal valve, which was biopsied and was a tubulovillous adenoma with low-grade dysplasia on the biopsies. 1 polyp in transverse colon, which was resected, and 1 polyp in the rectal area, which was also biopsied, and that was a tubulous adenoma with low-grade dysplasia. And the polyps were of that concern to the endoscopist that he referred the patients to this center.
Right.
So I just at one edge of that, you were just washing some mucus off there, David, just at the anal end of it.
Mm-hmm.
Are
you concerned about it, or?
Well, no, just if you come slightly further back, I just thought, how often do you see any sessile serrated tissue adjacent to a lesion like this, or is it never?
This is not of course, this is not a sessile serrated.
No, I appreciate that. I just thought, anyway, it looks clear with washings.
So the 2 things that give you mucus are the SSLs, but a villus component to the adenoma could pump out lots of mucus.
Yeah.
So this has got it will have villus component to it. Yeah.
All right. So I think this is a nice one. I said already that just to remind me, how much colonoscopy polypectomy experience have you got?
Hot snare, like 20 to 30, so not that many.
All right. So we've got 2 people in the room, and I'm making a judgment about who's going to make an imprint on this. I know Zander's things relatively well, and I suggest that we mix it up a little bit. And so I'm not sure either of you is going to be able to complete this, but I would suggest that we can get you both doing a little bit of this. So first thing to do, decide if it's cancer or not. We've decided that it's not. What's its covert risk of cancer? The risk of buried cancer in this?
It's granular. It has maybe like a predominant nodule.
It does have a nodule.
So that's something to be aware of.
But it's not in the rectum?
It's not in the rectum, no.
So what would be the risk of this one then, if you were going to judge?
3%.
Quite low, but yeah, I think it's quite low.
I think it's probably something approaching 5, maybe 4 or 5. Okay, this is not a young man, is it? So,
No.
So therefore, I think we can be acceptable with piecemeal resection. Hot or cold?
So it's 6.4%.
Normally, Lynn, you can do that in your head.
I did it, but I was on mute. I was shouting when I was on mute.
Yeah. Okay.
Hot snare.
Hot snare, okay, because I think we know that the evidence base for cold in this situation is not established, even though I think it's possible. We should not be doing it outside studies. All right. And the last thing is piecemeal or en bloc?
Well, concerning the age of the patient, probably piecemeal would be fine.
would you ever attempt en bloc or something like this?
I would not.
I think it's not an acceptable solution with a snare in the right colon, personally, but okay. And it is on the fold of the ileocecal valve, isn't it? It is not involving it. No. Okay. Last thing then, we are going to get Zander to do some. We'll get a defect assessment on the other side. Anything else we need to know?
Just because I work with snare.
About what you want to use, what equipment you want.
So I'd probably start here. Just here.
What are you going to? So you've got an injector. What kind of? Yeah. What snare size are you thinking?
To the bottom. Okay. And it falls out of your field of use your working.
I think 15.
Okay. Yeah, I agree with you. A 15mm hot snare. Yeah. All right. So in terms of plans, Anna, what are you thinking?
The snare master stiffer, but I'll use captivate.
So I would try to firstly do the more difficult parts, or maybe.
So I don't think you need to worry about that. I would start in a place where you feel comfortable and work into the plane. So where's an easy place here?
Maybe on top.
Exactly, right on top. So the problem with that, as John will immediately start shouting out in a minute, is that if you do that, you're going to be sitting down onto polyp when you cut.
Yeah.
So maybe it's not the most ideal place to start. Another place you could start might be down here on this flat part here.
Yeah.
You could bring that out and start getting into the plane there, because of course this thing is over a fold. So it's going to require at some point you to access that area. Or you could lift up the front here and start lifting there. The slight issue being that it's not so easy to see what's going on there, but yeah.
And is it an option to start at the bottom, lift it here? And start at the
This is an option. Yeah. I think that's what I'm meaning here. This you can start.
So here underneath.
Yeah.
And this. Probably I'm just going to start here.
Perfect. All right. So let's see what happens. Yep. Try and get this fluid out first, maybe.
David, it's probably worth mentioning gravity's down at the bottom. So unless you're going to move the patient again, starting at the bottom is probably a good idea. So the polyp pieces fall down around your feet and not into where you're cutting next.
Yep.
And also you can then follow the V up the resection margin from 6 to 12 o'clock.
Yep.
So I'd probably start at the bottom.
Yeah, and I think you can choose whether you start here or in that depression. Because there's still a polyp there, isn't there?
Seems pretty good, doesn't it? Good tip control, yeah.
That's that.
So you could probably go more than that, Xander. I would use the same place you went to just do a bit more.
Just a bit more down?
No, I would use the same place, because we've learned one thing today, is that you really don't want to be making multiple injections for your first piece, that it works well to do one.
Yes.
Back in the same place or similar place.
Okay. That's good. Yeah.
And then just really sit there and let it come up. Really lift the tip up more. Up in the air, up in the air. Yeah, that's it. Okay, so this is going to be good now, I think. We've got a whole load of normal we can take at the front, which is what we want to do. Now you've got a choice about which snare. You want a stiff snare or you want a floppy snare?
Look here now.
You just pull back a bit and suction the gas out and it will be okay. I think. Often that happens when you get too much distension.
Yeah.
The English are looking at the scope guide and almost as good as on mute and maybe not watching.
More injection? Probably not.
Yeah.
And it's torque, usually, that's the key. Look at that. Yes, exactly. Yeah. Just a little bit, pull back a tiny bit. Yes, perfect. Right. Keep it there. Do you need holding to keep it there, or is it going to be good?
Maybe a little bit of holding. Just, yeah.
Okay, it's almost perfect. It's just a little bit too much push out, I think, in between the two. No. Push out a bit. Yeah, that's good. All right. Suction. And then, yeah, we'll do it. Slowly close. Get that. Yeah, well done. Okay, he's got a big piece, John.
Yeah, I think it's good, David. You'll test for mobility, but the technique is such that this is safe to take this off.
Yeah. Okay, take the snare, go to 1 centimeter. So now practice this time. Do not let me hear a click, right? So get this here, get it like that, and then just focus on that. I will not close my hand.
Yeah.
Just let the diathermy do it. Right. I wasn't back. We see the video of us. So is Xander here somewhere? Yes, Xander. Well done is the first thing to say. I think we can all say, well done. It was a difficult thing that you did there. So if we just go back to the start of it, I thought, and then John is going to say, well, you thought you did well. I thought the things that you did well were you were very meticulous, your tip control was very good, and you really thought about a plan. So, okay, there was a bit of prompting, there's a bit of discussion, but we really talked about, didn't we, whether to start down here, whether to start up there, what we were going to do, and you followed your plan, and your plan worked. The only thing that didn't work very well was the initial injection, and I think that's because we had the wrong position. We then repositioned the patient. I forced you to stay longer with the injection in one place and not put multiple places, because if you put multiple places, your snare is not going to sit very well. So here, what you're doing is is too en face. Like you have the tip like this and the mucosa like this, and you don't really get a good burn. You have to sit it down on it. And you see the difference between that, and you're getting not enough rim there. And then the difference between that and, I guess this sort of thing where I'm actually too far from the scope. I don't like it like that, but I see it's going to be difficult. And you see the plastic is just coming in on the edge. So that's one thing to do. And also another thing to do is, here you see me controlling the snare catheter with my hand, because the scope is actually quite stable. Sorry, Xander, but this position wasn't so bad for your polypectomy, even though it was beautiful. And so it means that you can take your hand off the scope. But as soon as you have to then go underneath, then it's more difficult to do that. Or if you're in a difficult position, you have to have that stable. But I thought your tip control was very nice. I don't know what they found the score to be, but I'm sure that it wasn't bad at all. And the part that you did at the top left is good. A couple of things to say about snare tip, soft coagulation, and margin. If it's not complete, you might as well not bother doing it. So you must complete it. In the validation studies of this technique, the incomplete margin ablations have recurrence rates up to 25%. So, and the ones that have complete are 1 or 2%. So make sure it's complete. And what we mean by complete is what this looks like a really decent 1 to 2 millimeter rim of white all the way around the defect. You also nicely assessed the submucosa and found it to be not necessary for treatment. So well done, Charlotte.